Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a very interesting case. It's of a patient who attended with multiple ear pathologies, and during the course of the video I'm going to address each one of those and try and explain what they are and why they've occurred and how they're treated. So this is the patient's right ear. You can see at the entrance the patient's got loads of hairs. Now these hairs should only be located and found on the outer third of the ear canal. If you think about the ear canal in thirds, so the outer third is cartilaginous, it's lined with a thick layer of skin about 1 millimeter in thickness, and also the cartilaginous portion of the ear canal contains these hair strands. Now at the root of these hair strands, so that the hair follicles, there's a couple of glands there. You've got the sebaceous glands, which secrete an oily, fatty substance called sebum, and that's the same substance that we found on our scalp. And also, depending upon whether you've got the specific gene mutation, you have a modified alpocrine gland, also known as ceremunous gland, and that secretes an oily sweat. It's the same sweat you find under your armpits. So all that's located on the outer third. The inner 2/3 of the ear canal, the bony part of the ear, you've got the thinnest layer of skin, less than 0.1 millimeters in thickness. And there's no hair follicles there found in the bony portion. So you can see as we enter the ear beyond the outer third, there's less hairs there. Now these hairs are hairs that are extending from the entrance and have just stuck itself to this dead skin that the patient's got. So let's explain what's going on here. Now, this patient originally attended about 10 months ago, and when they attended, they had a condition called mastoiditis, and they also had an active tympanic perforation, so a hole in the eardrum. So mastoiditis is an infection of the mastoid bone. Now, the ear canal is encased within the temporal bone. So the temporal bone is the bone that's found around the ear canal. The ear canal is made up of the temporal bone. It's one of the strongest bones in the body, I think behind the femur. And at the back of your ear, you'll be able to feel it yourself. So if you get your finger, go behind your ear, you'll feel the flat piece of bone there, and that's called the mastoid bone, and it's part of the skull. Now, the mastoid bone is porous. It's kind of like a honeycomb structure, so it's got loads of air gaps in there. And mastoiditis is an infection of the mastoid bone. It typically occurs due to persistent and chronic otitis media, so a middle ear infection, when there's a buildup of infected fluid in the middle ear. And that's normally caused due to a blocked eustachian tube, and the porous bone absorbs all the infected discharge and it gets infected. And mastoiditis can actually be life-threatening if it's not treated. The mastoid bone, as I said, it's part of the skull, it's just below the brain, and if that mastoid bone gets infected, the infected bone can travel upwards towards the meninges, so that's a jelly-like membrane that coats the brain. That can lead to meningitis, a brain abscess, and it can be fatal if not treated. So the hallmarks of mastoiditis is a swelling of the back of the ear, inflammation. It can also tilt the pinna, so the satellite type of cartilage externally in our ears forwards. So it normally comes with those presentations. And so this patient had mastoiditis. Get them referred to your private ENT quickly as possible because of the current waiting list. So patient was happy to see a private consultant who did a CT scan, confirmed mastoiditis, initially treated it with antibiotics. They had a follow-up scan, and I think they're just awaiting the results now to see whether or not any surgery is required. So if they do operate, it's a surgical procedure called a mastoidectomy, and that's when the ENT surgeon drills out all the infected mastoid bone to prevent the infection from spreading upwards and causing other potentially life-threatening conditions and pathologies. So that's where the patient was about 10 months ago, and I think they got their follow-up appointment in a couple of weeks, so it's just around the corner, but they weren't able to wait any longer to have their ears cleaned, so they arranged to see me again. They've also had an active perforation, a hole in the eardrum last time as well. Now, all this I'm removing here, it's not earwax, it's dead keratin. So the ear canal and the outermost membrane, so the lateral membrane of the eardrum, is lined with a layer of skin. So it's an epithelial layer of skin. It's the outer part of the skin. And the ear has evolved in such a way whereby as this epithelial skin dies and sheds, it's got the unique property of moving sideways. It's just programmed that way. It's just a internal hardwiring that the skin knows. It's almost like salmon when they are giving birth, and they always return back to where they themselves, to the same stream even, from where they were born to spawn themselves. And it's just, the skin has just been, over years, it's evolved in such a way, as I mentioned, just to migrate sideways, or it should do, out of the ear. Now, the skin is called a keratinous, stratified, squamous epithelial skin. And when the process of the skin migrating, we call that epithelial migration. Now, keratinous, the word keratinous, it refers to the protein keratin. Now, the skin, as I said, it's an epithelial skin. It's very, very thin, but it's a type of a flat cell, almost like a pancake or scale. And we call that squamous. That's what squamous means. It just defines the shape and structure of the cell. So it's almost like a flat pancake, almost like a fish scale almost in physiology. And stratified means layers. So there's 5 layers of this epithelial skin that forms the epithelial skin. Now, the innermost membrane, that's making contact directly on the canal wall, we call that the basal membrane. And that basal membrane, it's rich in blood supply and nutrients. And as that skin cell replicates itself, so cell division, we call that mitosis, it's forced upwards by the sister cell. So the cell that it's just reproduced pushes the parent cell up away from the base of the canal. So it's further away from the blood supply and the nutrient supply. And then it gets pushed up again in a cycle until it's on the outermost layer, so the furthest distance away from the ear canal, which means it has the least amount of nutrients being passed through and blood supply, which then means that skin cell, the outermost stratified skin cell, begins to die because it's not getting all the nutrients it needs, all the blood supply, and all the fluid, the intracellular fluid, the cell finds it harder to retain. So that fluid seeps out, and that's why you get dead skin is normally quite dry. And what replaces the fluid is a protein called keratin. Now, keratin is actually quite important in a way. It's hydrophobic, so it helps repel water out of the ear, and it helps protect you from harmful UV rays. So it has got some clinical benefits. Now, this skin that we've just been peeling away, and as I've been talking, you've probably seen me just peeling it away off the canal wall. I've used forceps. It should naturally migrate out of the ear like a conveyor belt. And then any wax sitting on the surface of the skin is also naturally transported out of the ear. So the ear, in theory and in design, should be self-cleansing. So the skin dies and it sheds and it moves sideways out of the ear. Then you get another layer of skin that's formed underneath, and it's a continuous cycle. And the skin migration starts from the centre of the eardrum. So if you've been watching my videos in the past, I've always compared the eardrum to a pond. And then if you put a pebble right in the middle of the pond, you get the ripple effects. And think about the ripples of being dead skin that's moving sideways out of the eardrum, onto the ear canal and out of the ear. And the rate of migration does vary. It can vary from kind of 1.5 millimetres a month to 3 millimetres. And if you average an ear canal being 3 centimetres, for example, then this kind of a more average rate of migration being 3 millimetres a month, it can take up to 10 months for the skin from the centre of the eardrum to die and shed and migrate completely out of the ear. Now, why is this patient's skin failing to migrate? Why is it all collecting deep in the ear? Why is it crusted around the ear canal? Now, it could just be, well, there's a number of reasons. Some people, they lose the ability for the skin to migrate. For example, some patients who undergo radiotherapy around the ears, the process of undergoing radiotherapy can stop the skin from migrating. Now, in this particular case, I've got a feeling it's to do with the ear anatomy. Now, I mentioned before at the beginning, we know they've got a history of mastoiditis, and it may not be related to that, but you'll see it right at the end as well. I'm going to do some annotations. The back part of the ear canal, you may see it yourself here, near the eardrum, so we call that the posterior, so the back part, medial towards the eardrum. The ear canal bulges inwards, and it's almost distorted the shape of the eardrum. The eardrum's, think about an eardrum being like an oval, but in here, the top part of the eardrum looks okay, so that's where I am now. But the lower half of the eardrum, it's really narrowed. It's almost like a V shape there. And the bone from the back is protruding outwards. Now that could just be, it could be due to the patient's mastoiditis, because the mastoid bone is in that position. It's behind that bone there. That's the temporal bone, and the mastoid bone sits behind that. So if that mastoid bone is severely inflamed, it could potentially be pushing the temporal bone forwards. Or it could just be the patient was just born like that. It just had a bulging posterior canal wall. Sometimes people can have stenosis, a narrowing of the ear canal due to chronic outer ear infections, or surface ear, so exostosis, and that's when the bone deeper in the ear, in response to cold wind or air, the blood vessels dilate, and that helps to stimulate bony growth, so you get bony spurs, and that can also cause the narrowing of the ear canal. In addition, the patient's got quite a prominent, on the opposite side, on the anterior canal wall, the front part, there's a bit of a recess, and that's where I am now. I'm just busy trying to peel off skin. So essentially, near the eardrum, this patient's ear canal is narrowed, and it could just be as the skin's migrating off the eardrum, it's collecting in this narrowing, and it's unable to fully migrate because of the curvature, the bends, the narrowness of it. And that's one potential reason I feel the skin's failing to migrate. So again, there's no wax, it's pure dead skin, keratin. And you can see we're here, just here now, we're peeling the skin. It was almost hidden in the anterior recess, and it just wasn't able to escape. So it's very likely the cause of all this skin. Now, you'll see anteriorly, so to the front part of the eardrum, you can see it pulsating there. Now, at first, I was wondering, is this an active perforation? But I don't believe that is. In fact, I did a pressure test to confirm it. And so the eardrum is made up of 3 membranes. The outermost membrane, as I mentioned before, it's the same skin that lines the ear canal, and that skin dies and it sheds as an epithelial skin. The innermost membrane, so we call that the medial membrane, is a mucosa membrane. So the mucosa is a secretory type of skin cells that similar to the ones found in our nasal cavity, in our mouth. And then in the middle of those two, sandwiched in between, we have a fibrous and connective tissue membrane. So when you have a perforation, I'll come back to that. So that's the curvature of the posterior medial canal walls. You can see it's kind of bulging outwards there. And again, I've got that outline there. And then to the right, that's the part of the eardrum that's the pulsating eardrum. That's where the hole is, and you'll see it in a minute. It's kind of pulsating there. So if it was an active perforation, the discharge, so all this fluid behind the eardrum, that's what's causing this pulsing, would be collecting in the ear canal itself, but it's not. So I have a feeling, so when you have a perforation that's healed, it's, quite often the outer membrane, so the epithelial skin, and the innermost membrane, the mucosa, that heals with a perforation, but the middle membrane doesn't. So it creates an illusion that there's a hole there because it's a thinner part of the healed membrane is always a thinner part. So instead of 3 membranes regrowing, it's only 2. And I feel that this membrane has healed, either the outer or the innermost one, and it's caused a thinning of the eardrum, and you got fluid there pulsating. So I hope you enjoyed that video, guys, and you found it interesting and slightly different. Hope you're all keeping well, and remember, be nice and be kind to each other. Thank you. Bye.